Thank you very much for Dr. Dhammika Seniratna and the transfusion physician, the chairman or the president, Anuradhapura Clinical Society, and welcome all my colleagues and some of my students. Thank you. Today I am talking about glucose transport. Glucose transport is mainly through two molecules. One is a facilitative or non-energy dependent, other one is energy dependent, and other one is sodium coupled carrier system of sodium glucose co-transporter. Both transporters belong to the families of solute carrier gene series. So there are 43 families with 298 genes. First, I will talk about GLUT or facilitative glucose transporters. There are 14 members of the GLUT family. There are 14 members of the GLUT family, which can be divided into main 3 subfamilies. And the expression of these 3 classes, so they are artificially divided into 3 classes due to the function, are written here, and I'm not sure whether you need to remember it, but the important thing is testis is GLUT 14. I will just describe few things. So I've said, although it's down, it's not unimportant. So the GLUT1 is the erythrocytes and brain, or what you call blood-brain barrier. GLUT2 is the pancreatic islet cells, which is slightly different from the normal glucose transport. It's a high capacity, low affinity glucose transporter. And then the GLUT4, which is usually involved in usual glucose transport into the cells. Then there are class 2 and class 3. I have, and some of them are not only, GLUT5 is the only fructose transporter. Then there are various things, other transporters are there, which I won't bother you with detail. This is the beta cell, and the beta cell is actually activated by the slow glucose intake through this GLUT transporter, which increases ATP, and this closes the potassium channel. The potassium channel is closed, and due to the depolarization, calcium goes in. Calcium goes in, and then the insulin is released. That's the usual, normal mechanism of this thing. However, there can be some abnormalities with this potassium channel. And when there are gain of function abnormalities of this potassium channel can give rise to neonatal diabetes. And here, this next to the potassium channel, the sulfonylurea receptor is there. And repaglinide groups of drugs and the sulfonylurea groups of drugs, all glinides and sulfonylureas act through that channel. The muscle is slightly different. The activation of GLUT4 is by the insulin. So here the initial, here the activation of GLUT2, or this is the initial step, and this is the final step. And this inhibit, or the feedback inhibition of the glucose uptake is by the insulin release. So anyway, this is the first step here, and the ATP production is the second step. But in muscle, the first step is the insulin active insulin, this thing, and then signal transduction and the membrane depolarization closing the GLUT4 to allow the glucose to come in. So this is the slightly different way of activation. So that's the main difference between GLUT2 and GLUT4. So I'll describe the hypoglycemia unawareness. These the normal glucose levels in the what happens. These GLUT1 is in the blood-brain barrier. So the glucose go through the blood-brain barrier and through the GLUT3 it goes to the neuron. Normal component of high affinity GLUT1 on the vascular cell of the CNS during euglycemia, and an appropriate amount of glucose diffuses across the blood-brain barrier and goes through the neurons. This is a normal situation. What happened in the chronic hyperglycemia? So there are a lot of glucose here. There is a what do you call down regulation of the GLUT1 receptor. GLUT1 receptor is down regulated, and then glucose, normal amount of glucose diffuses across the blood-brain barrier and it goes to the neurons. So the brain glucose, amount of glucose in the brain is regulated. Okay. Sorry. Yeah. So chronic in normoglycemia, what happens? When the blood sugar becomes normal, the glucose is low. The GLUT1 again still down regulated. So the after treatment here, so we treat these with these chronic hyperglycemia. We treat the patient with insulin and tablets, and the patients become normoglycemic. The usual amount of glucose goes in, and the neurons, there is enough blood sugar, but adrenergic symptoms occur usually if the blood sugar goes below. What happens when there is frequent hypoglycemia? Frequent hypoglycemia, what happens? When these, there are a lot of, so this is what you call normoglycemia. What happens when the blood sugar comes down to the normal level? From the these normal glucose levels, this chronic hyperglycemia. So the GLUT1 is down regulated. But when if the blood sugars are down regulated, patients will feel hypoglycemia even if the blood sugar is normal. Patient will feel the hypoglycemia if even the blood sugar normal because GLUT1 is down regulated. Will feel. However, the adrenergic symptoms will occur, and adrenergic symptoms will cause patients to shift back to the normal glucose level. When there is frequent hypoglycemia, what happens is there is a lot of frequent hypoglycemia, the GLUT1 again gets upregulated. GLUT1 again gets upregulated, glucose comes in, and there is enough glucose in the CNS. There is enough glucose. However, the blood sugar is low. When the blood sugar becomes low, because the GLUT1 GLUT1 doesn't take in enough. GLUT1 takes in enough blood sugars, even if the blood sugars are low, because the GLUT1 is upregulated. Blood sugar goes to the CNS normally. And there is CNS blood sugars are normal, although the body blood sugars are low. That's why when there is frequent hypoglycemia unawareness occurs. Anybody find it difficult to understand that? Because I slightly missed one step. I can go through it again. I'll go through it again. So normal glucose level is this. Okay. When there's hyperglycemia, there's GLUT1 gets down regulated. So only down regulated, only few glucose, not all the glucose goes up. Glucose is regulated, and there's normal glucose level in the CSF. In normal, when the patient becomes normoglycemia, when the blood sugars get treated and blood sugars goes down, what happens is the GLUT1 is reduced because of the chronic hyperglycemia. GLUT1 is down-regulated. However, the blood sugar has gone down, not enough glucose goes in. Patient feels there is hypoglycemia. Although patient feels hypoglycemia, blood sugars are normal. That's why the patients with hyperglycemic patients, when you reduce the blood sugar to even normal level, sometimes they come and complain hypoglycemic symptoms. Do you understand? When frequent hypoglycemia occurs, the hypoglycemia unawareness occurs. That's also again because of the upregulation of GLUT1. Thank you. If there are any questions, you can. Okay. So there is what you call GLUT1 deficiency syndrome, blood-brain barrier. Patients have neonatal issues. So the GLUT1 deficiency causes low blood sugars in the CSF, and the patient will feel intact intercellular pathways, but the CSF, the transport protein is not there. Treatment is ketogenic diet. Again, GLUT2 deficiency. So then they have a hepatorenal glycogen accumulation, and there is a now the treatment for this is actually even for glucogen, what you call glycogen storage diseases becoming SGLT2 inhibitors. SGLT2 inhibitors are being successfully used for glycogen storage disease treatment. So this is the sodium solute importer family. There are what you call sodium glucose co-transporter, sodium myoinositol co-transporter, sodium iodide. These are the one which we use for radioactive iodine. So treatment, this is the principle behind radioactive iodine treatment. This is the sodium multivitamin and sodium proline transporter. How does small intestine take up and transport glucose? So the SGLT1 is mainly in the small intestine. Two sodiums go in and glucose go in. That's why we use ORS. That's the principle behind ORS to treat diarrhea or loss of sodium. SGLT1 deficiency causes glucose galactose malabsorption through the intestinal brush border and autosomal recessive disease. Severe watery and acidic diarrhea, which is fatal within few weeks unless nutrients contain glucose, galactose, including derived from corn syrup, are removed from the diet. So the oral dehydration therapy works via SGLT1 transporters in the enterocytes. The principle was SGLT1 and was elucidated by American and Bangladeshi scientists in early 1970s during the Indian-Bangladeshi liberation war. Sorry. She asked me not current. Okay, sorry about that. So this is the SGLT2 deficiency, familial renal glycosuria. So autosomal genetic disorder. Renal function is normal. Even with 50 grams of glucose lost, no hypoglycemia, normal GDT, no renal pathological or tubular changes, no CKD or UTI, normal life expectancy. So what happens when there is glucose? The glucose is almost 100% filtered by the GFR, And in the S1 segment of the proximal tubule, 90% is reabsorbed. And in the distal 2/3 of the proximal tubule, the other 10% is reabsorbed by the SGLT1. So the difference between SGLT1 and 2 is SGLT2 is almost exclusively in the kidney. The first part of the proximal convoluted or PCT or proximal convoluted tubule is the SGLT2 inhibitors. Actually, this part, the proximal convoluted tubule, is the part which is affected by the Rajarata kidney disease or CNAC. So I don't know this thing, but we have not given SGLT2 inhibitors to the patients with CNAC, but patients with diabetes, which is sometimes double pathology. They have the CKD plus CNAC, most of these patients, because they have almost everybody has kidney disease, and they respond favorably. We don't have any issues with CNAC patients with diabetes who are on SGLT2 inhibitors. So as what happens is SGLT2, they get sodium, glucose, both gets through the SGLTs. Glucose is pumped out by the GLUT2 to the blood. Sodium is taken out by the ATPase, sodium ATPase pump. Potassium is coming. So it's very easy. Glucose passively diffuses out of the cell through the GLUT2, and the sodium actively, or the energy dependent mechanism, it pushes out. These are just a small description of renal glucose handling. Physiological principle is saturation, and normal plasma concentrate or glucose that enters the nephron is reabsorbed. The tubule epithelium well supplied with carriers to capture glucose. If hypoglycemia, glucose will be filtered faster than the carriers can absorb. The carriers will become saturated and unable to reabsorb all the glucose that flows to the tubule. The transport at saturation is called the transport maximum. And sometimes this is transport maximum. So up to about 200 milligrams, all the filtered glucose, 200 milligrams in the blood, all the filtered blood sugar is absorbed. When it reaches about threshold like this transport maximum, these glucose get excreted in the urine. And sometimes there is a splay, what we call splay. However, the usual reabsorption mechanism. So when before the Tmax, sometimes there is some glucose get excreted in the kidney, because there is the threshold is not uniform in all the glomerulus. What happens when there is what you call SGLT2 inhibition occurs? This Tmax is lowered. So at lower threshold, glucose is excreted at lower threshold. Lower threshold. So අපි මේක පොඩ්ඩක් අහක් කරමු නේද? Okay. Okay. So now you can see better. So this is the EMPA international EMPA kidney study. So this 6,609 participants were given empagliflozin, and about 3,300 given placebo. And some of these patients are not diabetic. About more than half of the patients were not diabetic. doesn't work now. Okay, thank you. The primary outcome, progression of kidney disease or death from CV cause, occurred in 13.1 in the empagliflozin group and slightly higher in the placebo group. So it's significant. Hospitalization from heart failure or death from cardiovascular cause is again lower. Hospitalization for any cause, 24, about 25%, here 30%, around 29 to 30%. Death from any cause, again 4.5 to 5.1. Progression of kidney disease, significantly different, with hazard ratio 0.7, about 30% improvement in the kidney disease. So I think we should prescribe empagliflozin to all patients with CKD. That's number one. Then these are the new things which I'm going to this thing. The nephrolithiasis, I don't think it's very new, but I'll be talking about the new girlfriends of the empagliflozin later. These are again a large study published in Diabetologia, Danish Health Registry. So that these are not randomized control studies. One of the first randomized control study in Sri Lanka will be conducted by Dr. Vasanta Karunaratne, senior registrar in our ward, on renal stone disease. So the nephrolithiasis rate reduced about 2 per 1,000 patient years when you compare with GLP-1 receptor agonist. So I think it's my clinical experience also. I don't know why the science behind the how the stones get dissolved in the high sugar urine environment, we don't know. However, it is now being definitely proven. So this is again, this is a clinical trial, examination of the clinical trial or the post hoc analysis. So it's about 36% decrease in the renal stones reported in the patients who underwent renal stones everywhere. Renal colic, urolithiasis, calculus bladder, calculus urinary, calculus urethral, nephrocalcinosis, all those things. However, if you take everything, and analyze, favors this thing. But if you take individually, I don't think it helps much. So among diabetic patients, SGLT2 reduce the risk of, this is a new one. Okay. This is a new one. Reduce the pneumonia and septic shock compared with placebo. Our findings should be viewed as hypothesis generating, which concepts require validation in future studies. So risk of pneumonia and septic shock is also reduced. So there are a lot of new avenues that is being performed used by SGLT2 inhibitors, and there are again this DMJ visual abstract, chronic obstructive pulmonary disease. Again, it's in severe COPD, hospitalization, severe exacerbation is definitely low. Especially in COPD. So there are not only 1 or 2 studies, there are now about lot of studies are coming in about benefits in COPD. I do not advocate prescribing SGLT2 in renal patients. However, within next 2-3 years, I think there'll be recommendations. Renal stone disease, there is always now there is a trend towards prescribing SGLT2 inhibitors with potassium citrate or some other treatment for renal stone disease. COPD, I'm not sure. CKD, 100% sure. CKD we should give. COPD, I'm not sure. Renal stones, perhaps yes. So this is again large meta-analysis. Large meta-analysis, and they have definitely shown liver stiffness, improvement in liver stiffness measurement. The only thing that prevents large trials on empagliflozin patients is one thing is renal biopsy, necessary to do the liver biopsy in definitive improvement of non-alcoholic fatty liver disease or NASH. However, as everybody experiences, there is definite severe weight, not severe weight loss, about 5 to 10 kilograms of weight loss in patients who are on SGLT2 inhibitors. And that definitely improves the liver steatosis, insulin resistance measured by home IR and body mass index. So, and AST, ALT levels. So I think for non-alcoholic fatty liver disease per se, I would prescribe empagliflozin, but not for for chronic obstructive pulmonary disease or other infectious complications of COPD. But for non-alcoholic fatty liver disease, I will prescribe in addition to maybe pioglitazone. I don't think vitamin E is effective, but we can debate that. Thank you. If there's any questions, you can ask me. So diabetes definitely yes. I'll start metformin and then sometimes combine with SGLT2 inhibitors. In CKD, yes, definitely yes. With sodium bicarbonate, you can give SGLT2 inhibitors, which I have told. And then stones, probably yes. COPD, not sure. And what else? Non-alcoholic fatty liver disease, it's your choice. I think I would prescribe.